We are continuing with our discussion of HEMONC via case report. And so let's get started. The last case that we talked about yesterday was our ALL. Any questions on ALL? I know it can get confusing when we talk AMLs, ALLs, all of these different, shortenings of disease names. The most important thing that you can remember is that whatever you're seeing in your CBC differential, if you're seeing myeloblasts, call it an AML. If you're seeing lymphoblasts, call it an ALL. Don't make it any more confusing than it already is. Whatever they're telling you, just go with that for your answer, okay? So, case 5. Here we have an 18-year-old African-American woman presenting to her gynecologist for her first visit. She is generally in good health, but complains of menorrhagia since menarche. So what are we thinking here? We're going to build a quick couple item differential and then keep it moving. Excellent. And I agree with you. So not really a malignancy, thinking more along the lines of some sort of coagulopathy, some possibly a platelet deficiency, something to do with either your coag factors or your platelets, essentially. And so I agree, definitely. Let's keep it going. She notes that she bleeds profusely from cuts, but that she can stop the bleeding with prolonged pressure. Mother has the same problem. 2 brothers and her father seem to clot more quickly. Her maternal brother died in a car accident as a teenager, was rumored to be a hemophiliac. 2 of her maternal cousins also had menorrhagia, but neither they nor their mother had problems getting pregnant or any complications during delivery, pregnancy. Okay, so this is kind of like cluing you in that it's not less of a clotting problem. The patient's prothrombin time is 13 seconds. Her partial thromboplastin time is 62 seconds. Okay, so in this particular scenario, is anything kind of rising up on your differential? If this was your vignette on a question stem, what would you be looking for in answers? Okay. Excellent choice. So von Willebrand's disease is our answer here. So this is our most common inherited coagulopathy. It's autosomal dominant, and so we'll definitely see that family history picture when we're talking to our patients. Bruising, gingival bleeding, menorrhagia, bleeding out of proportion to trauma. And the type of bleeding that we're looking for, rather than being bleeding into joints that we see in hemophilia, this is more of places where you can bleed, you bleed extra. So, for example, in our gums, places we can bleed there, it's very vascular and very weak tissue. We can bleed there, we bleed more. Okay, menorrhagia, it's normal to bleed. You just bleed extra. Okay, that's the way to think about this versus a hemophilia. Defective von Willebrand factor plus a low factor VIII. Remember that von Willebrand's factor and factor VIII are married. They go everywhere together, and when they're married and together, they are stable. Okay, they're a really nice couple where whenever they're married and together, they're very stable. If you're missing one of these 2 factors, you're going to be low in the other. Okay, these 2 stabilize each other in the bloodstream, in the serum, and so when you're low on von Willebrand's factor, expect to be low on factor VIII. Okay, now von Willebrand's factor is not part of our clotting cascade. Okay, however, we do see this prolonged APTT. What's the reason for that prolonged APTT? Yes. So that you're 100% right. With defective von Willebrand factor, we can't make a nice platelet plug. That's the core issue here. However, does PTT measure our platelet formation? Mm-mm. Okay, that's all right. So PTT is going to be measuring our extrinsic or intrinsic coagulation pathway. Yeah. Extrinsic, excellent. So some of the factors in our extrinsic pathway, factor 12, factor 8, factor 9, those are, the main factors of our extrinsic pathway, and then you get to factor 10, and then it goes to the common pathway. Great. So what we said here is that with low von Willebrand factor, we're going to have low factor 8 because von Willebrand factor stabilizes factor 8. And so this is the reason that you end up with low factor 8, and that low factor 8 translates into a prolonged APTT. Okay? So if you were to get a question on that, just make sure that you're not making the assumption that von Willebrand factor is contributing to your PTT. It's not. It's from this other thing. Okay, great. So our ristocetin cofactor assay is essentially ristocetin induces platelet agglutination, but you need von Willebrand factor to do that. If you don't have it, then you'll see an abnormal ristocetin cofactor assay. Okay. DDAVP is essentially a synthetic external form of our antidiuretic hormone, okay? And it's called desmopressin. And what desmopressin does is it is going to go to our endothelial cells lining all of our blood vessels, and it's going to induce the release of something called a Weibel-Palade body. Okay, you probably remember this from your step 1, right? So Weibel-Palade bodies are full of von Willebrand factor and full of factor 8. Okay, so in the acute setting, if your patient is bleeding a lot, one thing with von Willebrand disease, there's about 5 or 8 different types of von Willebrand disease, all with different levels of severity. So but when you're talking to your patient, they're not going to know what level of von Willebrand disease they have. So if they have one of the more severe forms where there's a lot of bleeding, you want to stop the bleeding, you can go ahead and give desmopressin. You're going to release all those Weibel-Palade bodies, and that should help for the short period. After several days, however, your endothelial cells are going to be depleted of all of those Weibel-Palade bodies, and they're going to be depleted of von Willebrand factor. So that therapeutic effect is going to be gone shortly after. Okay, so the only other real treatment is just factor 8 replacement. Okay, that's the most important thing here that they're missing is this part of their coag pathway, and so we're going to go ahead and replace that. Okay. All right, and that's pretty much all you need to know for step 2. Not that much extra information over step 1 at all, really. Okay. Great. Any questions? Okay, I'm gonna move forward here to case 6. So here we have a 20-year-old college student brought to the emergency department by her boyfriend following a seizure. Okay, so for building a differential for a seizure, there's a lot there, right? But this history of, being a little bit younger, being in college, what sort of things are going to crop up on your differential? I'm sorry, what did you say? Oh, yes. Yeah, so that's true, right? In the context of this lecture, it's hard to think of something, but, keep it general. So, college students, they party, they do crazy things. So we're going to include things like, using different kinds of drugs, ecstasy, things like that can possibly, right, induce seizures. Other than that, she could have a history of epilepsy. We're not too sure yet. Okay, Great. So keep moving forward. Patient's still confused, but her boyfriend states she was complaining about abdominal pain when she woke up. They had attended a party the night before, and the boyfriend believes she took some sort of pills in addition to drinking. He reports that she has been on a diet. Her eating has been very erratic. Okay, so they're giving us a few things here to kind of push us in the direction of some sort of stress to the body, right? So, taking pills that she's not supposed to be taking or not used to, in addition to drinking, that puts a stress on your liver and its ability to detoxify the blood. Being on a diet means maybe she doesn't have the right nutrients in terms of being able to synthesize certain things, heme-wise. Okay. Physical examination, she's confused but responsive. Vital signs include slightly elevated temperature, heart rate of 115, and blood pressure normal. Abdomen is soft but groans on palpation, so that's giving us some abdominal pain. Neurologic exam is normal except for global areflexia. Global areflexia, so all of her reflexes are diminished. Foley catheter is inserted and returns 200 cc's of dark reddish-brown urine. Okay, so her urinary excretion of ALA and PBG is markedly elevated. Okay, is anything kind of creeping up a little bit more in your differential now? It's okay. What does it have to do with? Like, what pathway in the body? Hansen's disease? Basically for heme synthesis, right? Excellent. Yes. So this is what our acute intermittent porphyria, which is our exactly. I know what you were going for. And so essentially, we have an issue somewhere in this huge pathway that we really needed to know for step one, but never need to know again for the rest of our lives, right? Because you definitely don't need to know for step two. But you do need to be comfortable with several of these porphyrias we're going to talk about. So, in general, this is an autosomal dominant disorder. It is inherited. People are born with this. And they have some defect in their heme production causing an accumulation of porphyrins. In acute intermittent porphyria, the ones we look for is ALA and PBG. Okay, this was a question on my step 2 exam. They asked me exactly this. What are the porphyrins that accumulate in acute intermittent porphyria? Okay. I don't know if I'm supposed to tell you that or not, but I'm just going to tell you whenever I find something that was a question for me, I'm just going to tell you. Presents with colicky abdominal pain plus neurological abnormalities. Okay, so if there's anything to push you in the direction, the problem with the porphyrias and properly diagnosing them is you're not thinking anything to do with heme, right? Like when we started this question, there's a seizure and abdominal pain. It's like, what could that possibly have to do with my heme synthesis pathway? If it's due to heme synthesis, give me some microcytosis or give me some, low hemoglobin. You're talking about all this other stuff that has nothing to do with my red blood cells. So that's the trouble with correctly identifying these in a question stem, is that it doesn't pop right out to you. But if they give you anything that kind of gives you that hint of this might be a porphyria, really look for these two things: colicky abdominal pain plus neurologic abnormalities. Oh, really? Yeah. Yeah, good. So then you're already most of the way there. There's not really too many things in the field of medicine that give you abdominal pain with areflexia. The only other thing I could think of is something to do with calcium, right? When we have like a hypercalcemia, you end up with, the abdominal groans, and then also some, neurologic, psychiatric type issues. I mean, you could try and paint that picture, right? But in general, there's not that much that gives you abdominal pain and neurologic abnormalities. So having those two together, like you said, is something that should really point you in this direction. All porphyrias are going to present with this pink urine, and I made it pink. I spent time making that pink on this slide just for you so that you remember. that you are going to have that pink urine. Okay, it doesn't matter what porphyria is on this whole entire heme synthesis pathway, that will be there. Okay, so look for the history. Acute attacks are associated with anything that increases heme synthesis. Okay, so fasting, chemical exposures, alcohol barbiturates, OCPs, all of these are going to work at the level of the liver and tell the liver to kind of kick on some of the beginning of the heme synthesis pathway, where it will be finished in the bone marrow. And so look for those types of things. We're going to look in the stool, urine, serum porphyrin. At that point, we kind of have our diagnosis, right? Enzyme assays are going to be reduced erythrocyte PBG deaminase. This would be our very definite way of diagnosing this, right? Is to look for a reduced level of the enzyme that's missing. Okay. So our treatment here is going to be a high dose of glucose to decrease heme synthesis. Okay. So this idea of glucose reducing the level of heme synthesis, and you probably remember this from step 1. What glucose is going to do is when our body gets glucose, it wants to use that glucose for glycolysis and subsequently the TCA cycle. Okay, it wants to use up all that glucose for the TCA cycle. So if we use up all that glucose for the TCA cycle, the level of succinyl-CoA that's available for porphyrin synthesis and heme synthesis is going to drop. Right now, those intermediaries that we need to build this heme are not there. It's being used somewhere else. And so that is the way that glucose helps in these conditions. It takes away all of this succinyl-CoA and uses it for the TCA cycle. Okay? So in that way, we can help these patients. Also, if we have a severe attack, we can give IV Hematin. IV Hematin is just basically a heme that works on the heme synthesis pathway as a negative feedback. You can see here, we have heme spelled in a very strange way. I've never seen it spelled like that before, but that's fine. And heme has a negative feedback all the way on the first enzyme of the pathway, ALA synthase, excuse me. So giving your patient IV Hematin is going to stop this pathway from progressing forward, and any of the porphyrias in this pathway will be reduced. Okay? Great. So just our high yield points. Yep, autosomal dominant. Look for a college student, change of diet, plus alcohol or barbiturate use, abdominal pain and neuro findings, weird pee, and that family history is helpful. Porphyrins in the enzyme assay. Treatment's going to be glucose. Very easy, very efficient. Okay. Now, Porphyria cutanea tarda, I would say, is the only other of the porphyrias that you need to know for step 2. Right? You got to know your AIP, know all the details about it, and then know your Porphyria cutanea tarda. These two are the ones that come up the most. Whatever literature you use, you're going to notice these two they talk about more. And in my experience, these were the two that I needed to know for the exam. So with PCT, what we see is bullous skin findings. Right? We have these really nasty bullae on the skin, plus the pink urine that we see in all porphyrias. Okay, we're not going to have those neurological findings. We shouldn't have the abdominal pain. We're just looking for those bullous skin findings when your patient goes out into the sun and pink urine. Now, what infectious condition is associated with PCT? And I will give you a clue. It has to do with the liver, right? Because that's sort of where all of these problems are happening, is at the liver. I'm sorry? Hepatitis, yes. Hepatitis C is our infectious condition associated with PCT. So what happens? Your patient gets Hep C. Your Hep C goes chronic. Okay, goes chronic, and in patients with chronic hepatitis C, they have a high risk of developing a lot of different strange problems. They get vasculitis. They get this Porphyria cutanea tarda. They get different skin abnormalities. A lot of weird stuff if you look into hepatitis C. Okay. All right, great. Any questions on our porphyria? Okay, great. Okay, so we've got a 23-year-old man visiting his primary physician after 1 month of night sweats. So when you think night sweats, what are just like the first things that pop up? Okay. Okay. Okay, Hodgkin's and TB. I like that differential. He says for the past 6 weeks, he's had general malaise, which he attributes to the stress of his new job. Great. And he has lost about 10 pounds during this time. He's been healthy in the past, conscientious about eating a balanced diet, exercising, family history unremarkable, does not smoke. Everything fine. Denies international travel. Says he had a negative PPD test before starting the new job. All right, so now we're down to just Hodgkin's, right? On examination, his temperature is 100.5, blood pressure 120/65, heart rate is 80, respiratory rate, everything normal. Examination within normal except for, palpable cervical lymph node, which is firm, painless, and approximately 2 centimeters in diameter. Okay, so the results of the excisional biopsy are shown in the next slide. That looks familiar. You got it. Hodgkin lymphoma. This is a B-cell malignancy. B-cell malignancy. A lot of these cases are going to be associated with your Epstein-Barr virus infection. Reed-Sternberg cells are CD15 positive, CD30 positive. Okay. Here we're looking for young adults or the elderly, and then our patient was in his 20s, and so that fits with that. Typically a male predominance, and the nodular sclerosing type is more common in white folks. Commonly, it's early stage when diagnosed, early stage. You know, the fact that Hodgkin lymphoma is associated with these B symptoms means that patients are going to present, right? They don't like having night sweats. They don't like having all of this weight loss and fever. And so they're going to go to the doctor. Versus with our patients with non-Hodgkin's lymphoma, where they don't have these B symptoms, they're not going to know until it's very advanced. Okay. The other thing that really helps in terms of diagnosing Hodgkin's lymphoma is that when you have this swelling of the lymph nodes, they tend to be contiguous. Okay, when you have a patient with 3, 4, 5 lymph nodes in a row that are all swollen and painless, you know that's gonna upset them a little bit, so they're gonna come to see you. So risk factors: infectious mononucleosis with EBV, immunosuppression, mycosis fungoides, and HIV. We should look for these B symptoms, that contiguous spread, lymph node to lymph node in a row, painless lymphadenopathy, and yeah, so just kind of looking for these tough nodes. Look out for that SVC syndrome if it involves the nodes in the SVC area, and erythema nodosum as other potential skin side effects, things that you can see. Okay, and so just sort of comparing our Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's, we're looking for usually it could be younger or older, whereas non-Hodgkin's tends to just be over the age of 60. Prominent B symptoms in Hodgkin's. Non-Hodgkin's, oftentimes those B symptoms are going to be absent. They can be there, so don't use the B symptoms as, automatically this is Hodgkin's lymphoma. But typically, that's one of the identifying things that we use. The lymphadenopathy is going to be contiguous. However, for non-Hodgkin's, we're looking for generalized, non-contiguous. You can have one in your axilla and then one in your popliteal fossa, right? We can have them sort of all over the place. For non-Hodgkin's, it's a B or T cell proliferation versus Hodgkin's. It is a B cell lymphoma. However, we will see some Reed-Sternberg cells and then a lot of reactive cells. For Hodgkin's, we have a usually pretty good prognosis. We have that early diagnosis, which helps, versus non-Hodgkin's, where it can be quite advanced by the time your patient presents. Okay. All right, so case number 8. How about you read through this one and tell me what you think for a diagnosis? It's up to you. Okay. So, so that platelet count severely low, right? The lowest level that we like to see would be 50,000. This is 7,000. What about the white blood cell count? Is this normal? You're okay with this? Okay. And so we have a white blood cell count essentially of 6,000, platelet count of 7,000. So really just primarily a platelet problem here. And so, like you said, we can think of ITP, which is our immune type condition. Our immune system attacks the platelets, destroys them. We get low platelets. Okay, I like that. TTP, there's where we have those von Willibrand factor multimers that are just floating around in our serum and causing widespread destruction of platelets, widespread destruction of red blood cells. It's a microangiopathic hemolytic anemia. So we would see, our patient would be anemic essentially, and so sort of looking for the findings of that. So I think in this particular situation, I personally reading this, I would be pushed more towards ITP versus TTP, but they both belong in your differential, so I'm glad that you mentioned both. And your ITP is going to be your correct answer here. And so like we said, this is going to be our autoantibody mediated platelet destruction. And there's really two types of ITP that we can see. Our acute ITP is our patient that has a viral upper respiratory tract illness. Their immune system gets triggered, gets activated, and it sort of gets overactivated and causes a destruction of their platelets. Okay, and so that's our acute ITP. This patient typically doesn't have any history of having low platelets, but just sort of has this acute episode. All right, versus our chronic ITP, primary would be idiopathic, and secondary, which is the more common that you see, is secondary to predisposing conditions, exposures. So lupus, we can have those phospholipid antibodies attacking our platelets, HIV, lymphomas, and never forget that heparin-induced thrombocytopenia, very common inpatient cause of low platelets, secondary to antibodies. Okay. Sure. Yes, so the risk is high. Patients with chronic ITP, especially the primary chronic ITP, it's sort of like a lifelong thing that they have to live with. So they will get treated with it. We're going to give steroids and induce a remission. And maybe 6 months, 8 months, 1 year later, they're going to come back with low platelets again. Oh, the acute. Yes, so the acute, the risk is very low. It's like a one-time thing usually. Mm-hmm. Yes, absolutely. That's a good question. What is the risk of getting it again with acute ITP? It's usually just a one-time thing, and it's an explanation for why someone would have low platelets in a background of not having any other risk factors, right? And so the pathogenesis here, we're looking for an anti-2B3A antibody. That antibody is going to bind that receptor on platelets. It's going to cause opsonization and removal in the spleen. Okay, this is key. The fact that the spleen is very intimately involved with the pathogenesis means that we can utilize that in terms of treatment. If steroids are not working, maybe take the spleen out, right? That could be a possible treatment for those chronic ITP folks. All right. Now, that GP2B3A antibody, that is going to be for all ITP except for this heparin-induced thrombocytopenia, right? For heparin-induced thrombocytopenia, we're looking for an antibody to platelet factor 4, okay? PF4 antibody. Otherwise, this is going to be true for everything else. Essentially, with heparin, what's happening is heparin is causing a change in one of the proteins on the surface of your platelet, which causes the immune system to attack the platelet, okay? Versus, in this case, the immune system is attacking a perfectly normal part of the platelet, okay? All right, great. And so clinically, for our acute, this is usually going to be children. Okay, usually this is going to be a kid, has that viral upper respiratory illness, has no other health issues at all. And then all of a sudden comes down with these, epistaxis and bleeding from the gums, et cetera, et cetera. We check the platelets, there's 5,000 of them, and we can diagnose this as a acute ITP. Again, not a high risk of having this again, very, very low risk. For chronic ITP, this is typically going to be a woman, in the age, 35, 40, around this area, right? This is our most common immunologic disorder in women of childbearing age, okay? Our common symptoms, we're looking for petechiae, ecchymosis, everything that we look for with thrombocytopenia. Typically, the spleen is of normal size, and I know that kind of doesn't jive with the rest of what we've talked about. We said the spleen is playing a big role here and removing those platelets from the supply. You would expect it to be swollen a little bit, but that just happens to not be the case. Typically, the spleen is going to be normally sized. You can see more severe manifestations of bleeding. Very rare would be like a subarachnoid hemorrhage, intracerebral hemorrhage. That is very rare. That typically you don't see. So all in all, this is going to be a diagnosis of exclusion. We're going to take a good history, rule out everything else that causes low platelets. Okay, that means a lot of testing for a lot of different stuff. Normal coag tests, which we would expect them to be normal, right? This is involving the platelets, not coag factors. On our peripheral blood smear, we are typically going to see larger platelets. The reason for this is because our bone marrow is trying to pump out as many megakaryocytes as possible to replace the low platelet level, okay? And so we know that the way that platelets form is that you have this big cell called a megakaryocyte. As that big cell goes into the small capillaries of the lungs, the small capillaries in our extremities, it's going to be broken down. It's going to basically be just giving off all of these platelets. That's how these platelets form. We have a big cell, and it gives off a bunch of little cells. Okay, and so when we're pumping out a bunch of these big cells, relatively speaking, some of those platelets are going to be a lot larger because they're brand new. Okay, so we'll look for those larger platelets. On our bone marrow biopsy, we're going to have normal to increased megakaryocytes. Okay, just trying to increase the level of platelets. Treatment here, steroids. This is an immune condition, so steroids are going to be very helpful. Splenectomy. For patients that are not responding to steroids, we can give IVIG, which is your immunoglobulin against immunoglobulins, anti-CD20, and if we think that the bone marrow has more potential to make platelets, we can give some thrombopoietin mimetics drugs that essentially stimulate the bone marrow to make thrombocytes. Okay, and so two examples: L-Trombopag. And Ramiplostim, terribly named drugs, but there you go. Careful with platelet transfusions here. And, yesterday or our last lesson, we talked about how when we have a platelet level that drops below 20,000, we really want to think about transfusing. However, that shouldn't be our first action with these patients, right? These patients have antibodies to platelets. If we transfuse a bunch of platelets, their antibody level is just going to increase, right? They're going to respond to this as more of an invading organism or something like that. And so with platelet transfusions, that's not going to be the first thing you want to do. First thing you need to do is to knock out the immune system with those steroids, drop the level of immunoglobulins that are in there, and then if the platelet level is low enough, go ahead and transfuse at that point. Okay? Now, I sort of listed steroids and splenectomy next to each other here in terms of treatment. However, thinking about this realistically, if you have a patient with, a child with an upper respiratory tract illness, you're not going to take out the spleen, right? Just steroids, exactly. Yeah, excellent. Okay. Sure. Yes. Mm-hmm. 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 Antibodies. That's an excellent question. So, essentially, when do we want to transfuse? That yeah, so that's a tricky thing. I think that if your body is making platelets and you've tamped down the immune system enough that we're not making antibodies, we would start seeing a slow increase in the platelet level, right? These platelets are not working at the level of the bone marrow. They're working in our systemic supply. And so if we are seeing a slow increase in our platelet level that is consistent with a reduction of the amount of antibodies that are there, but it's kind of too slow and we don't want to risk too much bleeding, boom, go ahead and transfuse. Absolutely. The fact that your platelet level is going up means that your treatment is working against the bad guys, against our antibodies. Okay. Yes. So, yes. Yes. But so the trick here is that we don't have a good test for those antibodies. You'll notice in terms of our diagnosis, this is a diagnosis of exclusion. We don't look for anti-2B3A antibodies, right? So we need a sort of a secondary way of testing. And so what you described actually is the way of testing. We're looking at her platelet level. She should be able to make her own platelets. And so if we're seeing the platelet level increase from the baseline, that means that our treatment is working. The antibodies must be going down. Okay. Great question. Great question. Okay, great. So just our high yield points here. It's that antibody. By the way, with this particular 2B3A receptor, what is this responsible for? Is this responsible for platelets binding the endothelium or platelets binding to one another? Excellent, good. So this is for platelets will bind to fibrin, and then another GP23A will bind to the other side of that fibrin and essentially make this huge platelet clot in that way using this particular receptor. The receptor that is for binding the endothelium is going to be our GP1B9 or 1B3, depending on where in the body you're talking about. But yes, so the 1B. Okay, and there's all of these sort of genetic platelet problems, right? When you have a missing 1B9 receptor, that's going to be our Bernard-Soulier syndrome. In that, we look for inability to clot, and we look for big platelets on our peripheral smear, right? That's big sucker, Bernard-Soulier. That's our GP1B9 deficiency. We can also have a GP2B3A deficiency. That's our Glanzmann's thrombocythemia. Okay, and so those are two sort of genetic clotting disorders of platelets. Okay, but here we're talking about an antibody to that particular receptor. So. Acute ITP, abrupt onset of hemorrhagic complications in kids with a preceding viral infection. Chronic, insidious, slow onset. We're looking for an older person, and it's a problem that's been developing over months. And preceding infection, spontaneous remission unlikely. We're going to need to induce a remission using steroids. Okay. So, diagnosis of exclusion, we can look for those, increased megakaryocytes on bone marrow biopsy, increased platelet size on peripheral blood smear. Great. And so in terms of doing the splenectomy, when do we do a splenectomy? This is the type of stuff that CK likes to ask about, right? So your first line is going to be steroids. If you try and taper those steroids and then the platelets drop again, and okay, so let me increase the steroids again, and then let me taper the steroids again, and you still can't do it without the platelets dropping, you're going to have to take out the spleen. It's sort of like the end game, I think, for a lot of people, but you want to kind of push it as far back as possible. You can't leave your patient on steroids, right? We have a lot of other problems to worry about by leaving our patient on steroids. So we need to be able to taper. If you taper and platelets drop, you may need to take out the spleen. Okay? There's no like set rule of how many times you can try and taper. What I've seen is that usually they try 3-4 times, right? It's a few years before they decide, okay, you know what, we just need to take out the spleen. And a lot of it is going to come down to the patient. Like, you know, if your patient doesn't like being on steroids, some patients don't like being on steroids. If your patient doesn't like being on steroids, they may be more apt to say, okay, I want it out, versus a patient that doesn't want any surgery, et cetera, et cetera. That's sort of advanced beyond step 2 stuff, but just kind of bring it to the real world, right? Okay. Any questions on ITP? Great. You're actually asking very good questions, so I know that you're really in a good spot right now. Okay, I'll read this one. So we have a 43-year-old African-American brought to the emergency department after losing consciousness during a barbecue. Earlier that morning, when getting out of bed, he felt dizzy, had to steady himself against the doorframe of the bathroom. He's generally healthy, although he had a bad sinus infection for which he received trimethoprim, sulfamethoxazole, 4 days ago. Upon examination, he is tachycardic and tachypnic. His sclerae are icteric, but the rest of the examination is unremarkable. He's never been anemic in the past. Current laboratory studies show, depressed hemoglobin, normal white count, white cell differential and platelet count. His retic count is elevated, bili is elevated, and fractionation reveals that bilirubin is predominantly indirect. What's the most likely diagnosis? I like it, yes, G6PD. And so our G6PD, this is our X-linked recessive deficiency in a particular enzyme that's important for reduction of oxidization, right? Protecting our hemoglobin from oxidization. So G6PD is that first enzyme in our HMP shunt, produces reduced glutathione, which protects RBCs from hemolysis. NADPH also plays a role here, right? We sort of have a three-man group that ultimately produces this glutathione. We have the G6PD, we have our NADH as an electron carrier, and then ultimately our goal is to reduce glutathione. Without this reduced glutathione, hemoglobin can be oxidized, and oxidized hemoglobin is going to create those Heinz bodies that we know. Increased splenic destruction is responsible for the hemolytic anemia seen in G6PD. For our diagnosis, the peripheral blood smear is not diagnostic. You can't look at a PBS and say, oh, okay, this is G6PD. But, people that have studied this stuff recognize that seeing a lot of bite cells, maybe even seeing a couple of Heinz bodies there, that is really going to point you in the direction of G6PD. We can look for signs of hemolytic anemia, which is going to be our decreased haptoglobin, increased LDH, increased retic count. And treatment-wise, not really a treatment that we can give here. We really just need to avoid those triggers: sulfonamide drugs, favabeans, nitrofurantoin, malaria drugs, chloroquine, primaquine, things like that are sort of the triggers. And I put a slide in here as well with the mnemonic. I can't deal with this fucking shit. This is all of our drugs that can trigger a hemolytic episode in patients with G6PD. So isoniazid, ibuprofen, nitrofurantoin we mentioned, naphthalene, aspirin are anti-malarial drugs. It's really pretty nice that we know what an anti-malarial drug is. We don't really need to memorize this particular part. We just need to know all of those malaria drugs can do it. Chloramphenicol antibiotic, dapsone antibiotic, favabeans, and all of our sulfonamide drugs. And there's a whole list of those that goes on and on. Okay, so one possibly helpful way to remember sort of the more rare causes of hemolysis in these patients. Okay? Great. All right, so case 10, if you want to read through this one. Okay. Okay. CML or CLL. I'm really going to put it on you this morning, Daphne. Which one? Okay. Or hairy cell, now that you threw that one in there too. Okay, I like it. Yes. We have a lot of lymphocytes. So let's not make it complicated. This is going to be our CLL. The lovely thing about our CLL is that the chronic part, that word is really going to clue you into so many factors of this disease. Chronic, so I'm thinking something that's chronic has to be old, right? So we're thinking older patients. Chronic, meaning old, applies to the cells themselves. So rather than having lymphoblasts, which are immature, we have lymphocytes, which are mature cells. Okay, so that's the chronic part too. Third part of chronic, it's a indolent course. It takes a long time. I mean, this guy's been losing weight for 2 years and tired for 6 months. I'd say that's pretty indolent. Okay, that's a pretty slow moving course. Okay, so great, excellent. CLL, you're 100% right. B cell malignancy in older patients, median age is going to be 65. Definitely older patients. Proliferating B cells cannot recognize antigens, so look for that immunocompromise. Look for recurrent infections, low gamma globulins. If we went ahead and did a liver panel, we would see low level of total protein. Signs and symptoms. This is our most common leukemia. It is typically asymptomatic, but we should see increase in lymphocytes, of course, and splenic lymph node enlargement. On this patient, he had that hepatosplenomegaly, so that goes with it too. One link in terms of signs and symptoms as well that you can see is an autoimmune hemolytic anemia of the warm IgG type. Okay, warm autoimmune hemolytic anemia means that there's hemolysis typically happening within the spleen. Okay, versus our cold hemolytic anemia associated with more of our lupus. I guess lupus has warm IgG too. Associated with mycoplasma. Our cold IgMs and our autoimmune hemolytic anemia for cold autoimmune hemolytic anemia is going to be more in the periphery. Okay, so having hemolysis within the vessels. Okay, great. So on a peripheral smear, what are we looking for? Smudge cells. This is really one of the helpful things. If they give you this on a question stem, you put your hands together like this, say thank you Jesus. This is CLL, and you move to the next question. Okay. Small round lymphocytes can be helpful, I guess. Sometimes it's hard to differentiate these lymphocytes, right, from other types of cells. But that smudge cells really sticks out. And great. So on our CBC, we're looking for a vastly elevated white blood cell count. Okay. Typically, when you say, "Oh, my patient has a white count," we're talking 14, 15. The patient in this stem had a white count of 25. Okay, that is very significantly elevated. And when we do that white count, we want to see 80% lymphocytes. 80% lymphocytes. This is really going to be helpful in diagnosing, okay? And I hope you've seen as we've gone through here, we can really kind of make a list, ALL, AML, CLL, of what we want to see on the smear. So for ALL, we wanted to see greater than 25% lymphoblasts, right? AML, we wanted to see greater than 20% myeloblasts, okay? And now we're saying on CLL, we want to see greater than 80% lymphocytes on the CBC, okay? So that's pretty helpful. I think because, they're going to throw a lot of information at you on these oncology questions. I think it's what makes these questions difficult is when they throw a whole differential at you, right? CBC with differentiation, and you're seeing 20% basophils and 30% this, 20% that. You really just need to identify one thing in terms of getting your diagnosis. You should have a clue by the time you get to your CBC because of the age of the patient, right? Really because of the age of the patient. And then you look at that CBC, you see 25% lymphoblasts, ALL, go to the next question, okay? Great. The other thing that's very helpful if they give this to you in the question is seeing this CD5 on a B cell, okay? CD5 is a marker for what kind of cell? Sorry? CD5 is going to be a T cell marker. Yeah, this is for T cells. And so when you see CD19 and CD20, that's the classic B cell markers, right? That we get hammered into our head in our immunology classes, first year of medical school. CD5 is one of those T cell markers. That's one of the ones they don't talk about as much, but it is a T cell marker. Seeing a T cell marker on a B cell is very strange, very abnormal, and it's going to be your key to diagnosis here. If they give you that, that's another one where it's like, thank you so much. I'm going to take that information, choose CLL, and move to my next question. All right, so increase in expression of CD5 on B cells is abnormal. Great. This is going to have an indolent, slow-moving course. Richter's phenomenon is a transformation from this CLL to large cell lymphoma, and it's typically associated with a lot of presentation of a lot of symptoms, a lot of those B symptoms that we see in our Hodgkin's. We're going to see after this Richter's transformation. Okay. Eventually, some patients develop hepatomegaly, splenomegaly. Otherwise, it's a very slow course, with the exception of that Richter's syndrome. Okay. So treatment, this is really a pretty indolent disease. Doesn't really require treatment. If your patients are symptomatic, losing weight, like the gentleman in our question stem was, we can use fludarabine, which is a purine analog-based drug, to block synthesis of further synthesis of white blood cells. That's helpful. If your patients have that warm hemolytic anemia, you can give them prednisone, just sort of tamp down the immune system a little bit, prevent hemolysis, or a splenectomy if it's sort of recurrent and really causing problems for your patient. One thing to keep in mind is this drug, fludarabine, may exacerbate warm autoimmune hemolysis. Okay, so if they gave you in a question stem, this is a difficult question. They give you in a question stem, okay, here's a patient with CLL. We gave fludarabine, and now they have a hemoglobin of 8. What is the reason? You would want to choose warm hemolytic anemia as the reason. Okay, you would want to choose steroids as the next best step, and yeah. Okay, does that make sense? Great. Patients with severe refractory disease, we can do bone marrow transplant, but it's sort of not really the best treatment because a lot of these patients are quite old. Okay. Great. So just our high yield points here: B cell malignancy, looking a little bit older patients, most common leukemia. A lot of these patients are going to be asymptomatic. It's going to be diagnosed on our CBC, just like CML. A lot of times it's going to be asymptomatic and end up being diagnosed just by a regular CBC by their primary care physician. They're going to see this crazy number of white blood cells, and they'll investigate it further from that point. Okay. Increased expression of the CD5 on your B cells is particularly high yield. Make sure that you commit this to memory, jot it down somewhere. I'm sure it's already in your book, whatever you're using. But if it's not, jot that down. That is a helpful point for getting to your diagnosis. Okay. I'm sorry? Exactly. Yes. So what you're looking for is a cell that is CD19 positive, CD20 positive. That is your classical B cell, right? If you see a cell that has those two, you say, oh, that's a B cell. Great. Now, if you see those two plus a CD5 on the same cell, okay, that is not normal, and that should definitely point you in the direction of CLL. Okay, good question. Okay, and that's pretty much it for CLL that we can talk about. We can move on to our next case here. Let's see. Okay, so I'll read this one. We have a 3-year-old girl brought to the emergency department after being found unconscious in her bed. Cyanotic, respiratory rate of 4. Pulse is faint and thready. Mother is frantic, unable to provide a history. She does state that her daughter has a bad blood disease, which has necessitated numerous transfusions, particularly after a round of antibiotic treatment. I think at this point, you probably have a pretty good idea of what this patient's disease is, I would guess, right? So peripheral smear shows severe microcytic hyperchromic anemia with target cells and poikilocytosis. Thalassemia, excellent, yes. Emergency lab results revealed the following: white blood cell count normal, hemoglobin very, very low, hematocrit very, very low, MCV of 55. Holy cow. Okay, that is so crazy low. That's like half of a normal MCV, right? You have to think about the volume of your red blood cells is half of normal. That's ridiculous. Reticulocyte count is significantly elevated, where normal reticulocyte count is I think 1 or 2%. Okay, so yes, you are 100% right. Thalassemia is the answer here. Okay, and so alpha thalassemia are HB-H disease. We know that this is HB-H disease because she made it to the age of 4, and she's presenting with symptoms and a history of transfusions. Okay, so that tells us that's HB-H. Why am I emphasizing that? Because there's 4 different ways to get alpha thalassemia. Okay, you remember from studying step 1 that we have a gene from mommy and a gene from daddy, and each of those is going to have 4 alpha thalassemia codes on there, right? Not alpha thalassemia, excuse me, alpha chain of the hemoglobulin codes on there, right? Each of this is for an alpha chain. And so depending on the number of deletions or the number of mutations where we're losing some of these alpha chains tells us how severe the alpha thalassemia is going to be. So when we start with 1 deletion, this is completely silent, asymptomatic. Maybe you have some microcytosis, but you're basically never going to know that you have alpha thalassemia. With a 2 gene deletion, this is considered trait. We have some mild microcytic anemia, so your patient should be just persistently anemic throughout their life with 2 genes deleted. Okay. Now, when we lose 3 of our alpha chains, we only have 1 left. What's going to end up happening is whenever we are synthesizing red blood cells, we're going to be able to synthesize some hemoglobin. We're going to be able to synthesize about 1/4 of the normal amount of hemoglobin, right? Now, we're synthesizing alpha chains at that rate of 1/4. However, we're synthesizing those beta chains at the regular rate. Okay, so now what's going to end up happening is all of those excess beta chains are going to accumulate inside of our red blood cells and just be completely toxic and cause a lot of problems. Okay, and so these beta tetramers are what we call our HB-H. HB-H, okay? It's a hemoglobin because it has those beta chains, but it is not going to be able to carry oxygen. It's not really going to do anything but weigh down the entire red blood cell. Okay, so that's what an HB-H is. This patient is still going to have some normal hemoglobin, still going to have HbA, but also have HB-H. So moderate to severe hemolytic anemia, no abnormalities on hemoglobin studies, great. And now on 4 gene deletion, this is called HB-Bart. We have a gamma tetramer of just a bunch of gamma chains, which you remember is part of our fetal hemoglobin, right? Fetal hemoglobin is 2 alpha and 2 gamma chains. Because these fetuses never make it to full term, we can say that it's gamma tetramers, and these patients will die in utero via hydrops fetalis, and essentially they have no functioning red blood cells. Okay, so that's our 4 gene deletion, and our patient made it to 4 years old, so we know it's not that one. Hemoglobin H, these patients are chronically anemic. Splenomegaly is typical and something we should see. Also pallor, the normal things that we see with anemia. And how do we diagnose this? We're going to look for severe microcytosis. A lot of times when we talk about microcytosis, what we're talking about is an MCV of maybe from 80 to 70. Okay, when you talk about, say, your iron deficiency anemia, that should be in the range of 72, 75, that area. When you drop below 70, that's considered severe microcytosis. The patient in our question stem had a MCV of 55. That is a very, very, very low. Okay, and so that severe microcytosis is more typical of a thalassemia versus a iron deficiency anemia or something like that. Okay, low hematocrit level, all of the things from step 1 on our peripheral blood smear, I don't need to go over. On hemoglobin electrophoresis, we will look for this fast migrating hemoglobin, the HB-H, which is just a bunch of beta chains. Okay, bunch of beta chains stuck together. Our treatment here, we will give folate. Folate will enable our body to create our red blood cells more efficiently, and so we can have more red blood cells. Even though we don't have that much hemoglobin, at least we have more things to carry the little hemoglobin we have, right? We also need to avoid any kind of oxidative stress. If our patient is getting a lot of transfusions, we can consider a splenectomy. The spleen is going to be noticing these abnormal red blood cells and taking them out of circulation and dropping our overall oxygen carrying ability. So by removing the spleen, we can kind of increase our oxygen carrying capacity. And of course, we will need iron chelation therapy when we're having too many transfusions. Okay, so what drug would you like to use for iron chelation therapy? It's up to you, doc. It's okay. Deferoxamine is a pretty good one. I think this is what's going to be on in your answer choices. In clinical practice, there's a lot of different choices, but for us, we really just need to memorize this one. Deferoxamine, iron chelator. It's going to remove iron out of supply. Any patient with, say, like hemochromatosis will do the same thing. Deferoxamine is a really good iron chelator. Okay. Wonderful. Just sort of a review, a really nice picture that I found when I was making these slides of the different alpha and beta thalassemias. So for our alpha thalassemia, we're looking for excess beta chains. Beta, excess alpha makes sense. We have our chromosomes here, very helpful. And just a description of the different types of inclusions we see on each of these different red blood cell disorders. Okay. All right, and I will make this PDF available for you so you can review some of this stuff later if you are inclined to do so. Otherwise, yep, just a sort of our high yield points in review of what we talked about with alpha thalassemia. Do you have any questions on this? No? Okay, great. So we have a few more. Oh, no, actually, we're all done with cases. So after this, it's just a few questions that we can do, and we can do those quickly when we meet next time, which I believe is next Sunday morning, if I'm not mistaken.